Alexis, and I chose intellectual developmental disorder. This disorder was actually previously known as intellectual disability in the previous version of the DSM-5, and prior to that it was classified as mental retardation. However, with the change in, I guess we can say, vocabulary and appropriateness, we no longer use the term mental retardation, and moving from intellectual disability to intellectual developmental disorder just encompasses more of the range of symptoms that are evident in the diagnosis. So this diagnosis is a neurodevelopmental disorder, and it's characterized by deficits in general mental abilities. This can include things like abstract thinking, problem solving, reasoning, social interactions, and then also academic learning. And with these deficits, it leads to impaired functioning and lack of independence in various life areas. The DSM categorizes this disorder with 3 different criteria, all of which must be met. It's important to note that for the first criteria, the intellectual deficits have to be confirmed both by clinical assessment and individualized standardized intelligence testing. So in addition to utilizing these standardized testing tools, it's important that there's also a clinical assessment done that can encompass more testing of adaptive functioning, as well as, the background and history of the individual. And the onset of this disorder is generally during the early developmental period. However, adults can be diagnosed with this disorder, but in that assessment, clinical assessment, there should be some diving into whether or not there were delays in the early stages. The specifiers are mild, moderate, severe, and profound. I made 2 charts here that highlight the different levels of symptoms or criteria for these specifiers. I'm not going to go super into detail here, but for the severe and profound specifiers, you're going to obviously see more intense symptoms and higher deficits and delays. These 2 also encompass some maladaptive behaviors that could include self-harm, as well as other co-recurring physical and sensory impairments that cause barriers to, participation in certain activities. Individuals who have this level of IDD generally need support for all activities of daily living and supervision at all times. They may struggle and possibly not even be able to make decisions of general well-being for themselves or for others at that instance. But these individuals can learn skills. It's just that it's generally involved with long-term teaching and support. So approximately 10 in every 1,000 people are diagnosed with this disorder, and it's found throughout all levels of socioeconomic status, race, ethnic groups, and does vary by age. We see a higher prevalence in males in both the mild and severe specifiers over females. For the mild levels, we might not see any identifiable differences until school age when academic skills are being developed. This is whenever an IQ test could actually be presented. However, for individuals who have a more severe case, there may actually be more identifiable markers in language and motor skills and even social development around the age of 2. This diagnosis is generally non-progressive. It's a lifelong diagnosis. However, with early intervention, it has been found that it can improve adaptive functioning throughout childhood if a child is provided with the appropriate treatment. And in some cases, they could lose the diagnosis. But in addition to that, some other things to point out are that the onset may actually follow abruptly after an illness or an injury during developmental stages. This could be something like meningitis, a traumatic brain injury, etc. And for individuals who have genetic syndrome, like Down syndrome, you may actually see physical characteristics in appearance that are associated. But this is not solely a result of the intellectual developmental disorder. So as I mentioned, Down syndrome and other genetic mutations or chromosomal abnormalities can contribute to a high predisposition for the disorder, as well as any family history of genetic syndromes. In addition to that, there are things to consider during pregnancy, such as the maternal nutrition and healthcare or exposure to any substances like alcohol, drugs, infections, and even some harmful medications. We can also see deficits following complications with delivery. So, if there's a loss of oxygen to the mother or to the fetus, rather, this can lead to brain damage or any other neonatal illness. The same goes for postnatal factors. If a child develops, as I mentioned previously, any illness or infection that causes, damage to the brain, there can be deficits in cognitive function, which can possibly decrease previously acquired skills, leading to the diagnosis of this disorder. And then some important environmental factors to consider are socioeconomic status, if the individual is exposed to poverty, lack of health care, and I think the most obvious is chronic social deprivation. Some cultural considerations are that, obviously, as I mentioned, the diagnosis could be a result of, various environmental risks, as well as access to health care. But in some cultures, it is important to note that the disorder may actually vary in terms of whether or not parents believe it is a disorder, whether or not they actually report it, due to some things like, beliefs in supernatural influences, or that the disorder is a result, or behaviors are a result of punishment or presumed wrongdoing by parental figures. So with this, there are a lot of underreporting in certain countries. One that I can think of off the top of my head is Laos people. They have something called the spirit catches you. It's associated with a seizure disorder, but generally speaking, a lot of these children who have this disorder also have developmental disorders, the intellectual developmental disorder. But the parents don't realize that, and there's not much intervention. So, this association can lead to underreporting. So the diagnosis of IDD, we're just going to call it that for short for the sake of time here, has definitely progressed over the years. In the 19th century, we saw that individuals with IDD or any disorder, disability were actually seen as a disruption to society, and they were often placed in asylums and institutions. And then in the early 20th century, we saw progression in the understanding of genetics, and this led to researcher Alfred Binet actually creating an intelligence test we know as IQ tests, and they started to use these to identify children who had intellectual disabilities. Shifting into the mid-20th century, the term mental retardation actually gained prominence. It was appropriate at this time. Obviously, we don't use those words today, but it assisted with the medical model of disability, where there was a focus on diagnosing and classifying intellectual disabilities. And then in the late 20th century, between the 1970s and 1980s, again, there was a large shift towards more social and developmental research and a higher recognition for environmental factors, early intervention, and social inclusion. So where these individuals were no longer being left out of society, but rather, finding appropriate jobs and spaces for these individuals. And now, here in the 21st century, we've definitely evolved. We no longer use the term mental retardation in social or clinical environments, and our focus has moved towards, having an emphasis on intervention, education, community-based services, parental involvement, and such. One of the things I definitely wanted to highlight as well is that in addition to, clinical changes, there are also societal changes in regards to legislation. We developed the Americans with Disabilities Act here in the United States, which has also promoted inclusivity and equal rights for individuals with disabilities. And obviously, continued research in psychology and genetics and neuroscience will allow to provide more developments in the disorder and more support. I have a lot of assessments here just because this diagnosis does encompass so many different parts of the human experience. There are several ways to test to determine an entire picture. So, as I mentioned before, this diagnosis is, it generally doesn't, it doesn't stop throughout life, but there definitely are moments of more severity. And it's important that a child or an individual is tested throughout their lifespan to determine where they are. So a specifier could change depending upon the child's experience, whether or not they've received support or intervention, treatment, and so forth. So some of the first things, obviously, we use are IQ tests. There are two that I've listed here. Individuals with IDD generally fall within 2 standard deviations of average scores. But there are 10 of things that can obviously affect these scores. So we do not solely base the diagnosis off of IQ scores. There are other important things to use, such as adaptive behavior scales, and these evaluate communication, ADLs, socialization, and motor skills. In educational settings, you'll see the use of individualized education plans. And then I have listed here a bunch of other things like, as I mentioned, clinical interviews and history, developmental and medical evaluations. So primary care, pediatricians, they can also advocate for assessments. And then there's also genetic testing, observation, some more cognitive testings of memory, attention, executive function, and neuropsychological testing. Some other diagnoses to consider would be any major and mild neurocognitive disorders. The difference in these is that they are categorized by loss of cognitive functioning. And this means that the individual previously, had acquired these skills. So it's important to understand the individual's baseline. So in terms of baseline, how they were perceived prior to these deficits. But they can be co-occurring. Same thing with communication and learning disorders. These are specific to excess deficits in communication, but they don't show many deficits in intellectual and other adaptive behaviors specifically or independently. But they can, again, like I said, be diagnosed along with IDD. And then probably the trickiest one is going to be autism spectrum disorder. And that's just because there are a lot of symptoms that occur with autism spectrum disorder that can interfere with testing. And this could be from, social communication and behavioral deficits. So it's important to retest throughout stages of development as IQ scores may change and, the individual's skills, whether they're academic, cognitive, communicative, they can all change throughout time. So some treatments listed here, several different types of therapy for the individual. I like to highlight the two approaches that are probably the most popular: applied behavioral analysis. You see this used with children at very young stages, as well as CBT. Some important things are speech and language therapy as well as occupational therapy. These also are used for adults as well as assistive technology, dependent upon the severity of the diagnosis. And you rarely see medications used in these situations specific to IDD. There is not really a medication to fix, we'll put that in quotes because there's nothing to fix here. It's more of just assisting with learning, reinforcing these types of skills so that the individual has a better quality of life. However, individuals with IDD generally do take medications for other co-occurring conditions and behavioral challenges like ADHD, aggression and irritability for some of those more severe cases, or even anxiety and depression. And then one of the really big things I want to highlight here is that parents and caregivers also seek treatment throughout these stages. so that they can better assist their child throughout the process. As we mentioned, this is a lifelong disorder, so what better than to have every familial personnel be more aware, again, to provide them with a better quality of life. For my case presentation, I chose a 10-year-old boy who was referred for psychological evaluation by his school due to concerns about his academic and adaptive functioning. He is living with his mother and 2 younger siblings, one of which has also been diagnosed with IDD. His mother is a single parent and works long hours. But his teachers have noticed that he has been behind in his academic skills specific to reading, writing, and math, and that he requires extensive support in the classroom. He has very limited communication skills and often has difficulty expressing his thoughts and needs. We went ahead and did an IQ test for this individual with using the WISC, and his score was between a range of 50 and 55, which is consistent with intellectual impairment at a moderate level. We also used the Vineland Adaptive Behavior Scale to assess his adaptive behavior, and he showed deficits in the domains of communication, daily living skills, and socialization, all below his age group. And then, as I mentioned, it's super important to do a thorough digging into the developmental history of the child. Although the child is 10 years old, it's important to know what he was like at age 2, age 5. And in that assessment, the clinician was able to identify that he did have developmental delays from an early age. He was walking and talking much later than his peers. And obviously important to do rule outs as well, and that in the medical evaluation there were no underlying medical conditions contributing to his deficits. With this being said, he meets criteria for the intellectual developmental disorder mild specifier. He has deficits in 3 different academic areas of learning. We confirmed that he does have a below average IQ based off the IQ testing. He does require additional support in the classroom, and without that support, he can fall behind significantly in different areas of functioning, which can eventually have a substantial impact on his daily life and educational process. We ruled out a couple things here. The language disorder, his challenges in communication could be related to a primary language disorder rather than general intellectual impairment. So it would be important to do this, or to further test him, as well as the autism spectrum disorder, because there are definitely similarities in presentation with communication and socialization difficulties, as well as the potential for different learning disabilities like dyslexia or I can never pronounce that, I apologize. But this is again why testing throughout different stages of development is very, very important. I hope you guys learned a lot. I'm sorry, I feel like I sped through that super fast. Please feel free to take a look back at the PowerPoint, or let me know if you have questions.